We've been using EGFR tyrosine kinase inhibitors like gefitinib, erlotinib, Tarceva here, commonly known as Tarceva, and for a long time. The question really is, yes, we are doing a big effect in the therapy of advanced disease cancer patients, but where are we with early stage lung cancer patients? Can we cure more patients with EGFR mutation non-small cell lung cancer with the targeted therapies? So there is a big effort going on right now, and actually spearheaded by National Cancer Institute along with all the major cooperative groups, to ask the simple question: can we use erlotinib in the early stage patients with non-small cell lung cancer in order to cure them? So this is going to be an 8,000 patient study where patients will be screened before and after surgery, and we will be testing them for EGFR mutation in the resected tumor specimens. And we also be screening for the ALK rearrangement, and that's another subset. And if they have EGFR mutation positive disease, then they get randomized after the standard therapy, which is surgery, chemotherapy, or surgery alone. And then they'll get randomized to Tarceva or placebo, or erlotinib or placebo. And the whole idea is to see whether giving erlotinib in this setting, would that prolong the overall survival? In other words, will it cure more patients? And this is going to be a big effort, going to be done over several years with all the major centers and community centers participating in this. And our hope is to get about 450 patients or so with EGFR mutant positive non-small cell lung cancer to see whether really erlotinib would that make a difference in this setting. We hope to have the Alchemist trial up and going by late summer, early fall. And if it accrues over 4 or 5 years, it's going to take another few years. So it may take a good 7 or 8 years before we would know anything about the results of the study. But I think this is very important because till today we don't have the data on how much benefit or lack of benefit or harm there would be with the use of erlotinib in this setting. In general, physicians and patients and families assume that giving more therapy is better, but that's actually not true. Especially in the early stage disease, you could make an argument that erlotinib produces impressive results in the advanced patients, advanced non-small cell lung cancer patients. Why not use it in an early stage setting in order to cure this? What harm could there be? Sure, there could be harm, and we could have side effects which are sometimes nuisance side effects, sometimes they are life-threatening side effects. And more importantly, the big concerning question is that would that affect the biology of the disease in a way? And it may or may not favorably, it may affect or it may not affect favorably, and only a trial like this where we measure these endpoints carefully and study them would give us a real answer. And we shouldn't be doing this willy-nilly, and that's why the study is going to be very important. A few points to clarify about the Alchemist trial. So there'll be a large screening trial where there'll be 8,000 patients screened for 2 mutations, ALK transfusions, I should say, and EGFR mutation. And if they have EGFR mutation, they will go on the Alchemist EGFR trial where they get chemotherapy, surgery, followed by standard therapy, and then randomized to erlotinib or placebo. In the ALK group, again, standard therapy followed by crizotinib or placebo. And then there'll be this large group of patients who do not have these one of these 2 markers. So they will hopefully be funneled into some other therapeutic trials, perhaps immunotherapy or some such thing that are being developed. But more importantly, we are going to be studying all those 8,000 patients' tumor samples to see what kind of genomic alterations are there. In other words, what kind of genetic alterations are there that are present in the tumor cells that could tell us a lot more about how this tumor is going to behave. And I think after about 10 years, 8 to 10 years, we're going to learn a lot about, not only about the effects of these agents in this patient, but also on the biological significance of these alterations. And the primary endpoint for the therapeutic trial is overall survival. Physicians and patients shouldn't be taking the course of taking these medicines on their own, and we have to be part of a clinical trial so that we know clearly they are not harmed.